Hello and welcome to our talk on hypertension and everything related to its pharmacology. This tutorial is appropriate for medical students up to around the second or third year. The information used in this series was collated at the start of 2015, so if you're using this in the far-flung future, things like guidelines may be out of date. In this video, we won't actually be talking about how many of the drugs work. Those are for future videos. In this video, we will be talking about what is hypertension and how it's defined, what causes hypertension, when to initiate treatment, what treatment you should be giving, and how to monitor the treatment. So a logical place to start would be defining what hypertension is. In the clinic, when we take a blood pressure, we get two values, the systolic and the diastolic. Both values are important. You can also measure the difference between the two. This is called the pulse pressure. Narrow pulse pressures can occur in shock or congestive heart failure, and less often they can be due to aortic stenosis or cardiac tamponade. A wide pulse pressure occurs normally after exercise but can occur in a multitude of different diseases. Another useful measurement is the mean arterial pressure, which represents the average pressure exerted on blood vessels. 1/3 of your life is spent in systole, the other 2/3 of your life is spent in diastole. So on average, your blood pressure is 1/3 of the way between diastolic blood pressure and systolic blood pressure. It's just a useful measurement to make. So, in order to diagnose hypertension, we must have both a clinical blood pressure and a blood pressure reading that isn't subject to the white coat effect, i.e. blood pressure increases whenever the doctor makes any movement towards them. The latter can include ambulatory blood pressure monitoring equipment, that's hard to say, and this periodically inflates the cuff at home to measure a patient's blood pressure, or if that isn't tolerated, use a home blood pressure monitoring system, but this requires patient education to use. The first and least malignant stage of hypertension is qualified by a clinical blood pressure of 140/90. The non-clinical measurement is allowed to drop 5 mm of mercury below this, in both systolic and diastolic values. This is stage 1. Stage 2, you basically add 20 onto the systolic and 10 onto the diastolic. And stage 3, or severe hypertension, is when you have a systolic blood pressure of over 180 or a diastolic pressure of over 110. These definitions are useful to know because later we'll learn it determines what treatment someone gets. There are two main types of hypertension. The first we'll talk about is primary hypertension, aka essential hypertension, aka idiopathic hypertension. Basically, blood pressure will rise with certain risk factors, including but not limited to smoking, obesity, a poor lifestyle, high alcohol intake, high salt diets, chronically elevated stress levels, age, and certain genetic predispositions or even your ethnicity. For this tutorial, we're going to go over the management of essential hypertension, but it's worth knowing about secondary hypertension, which accounts for about 5% of cases. This is caused by renal diseases, endocrine disease, coarctation of the aorta, preeclampsia, drugs and toxins, just to name a few. You should always offer lifestyle advice for the reduction of risk factors to any hypertensive patient that walks through your door. It's free and there are no side effects to it. You should offer drug treatment to anyone less than 80 years old with stage 1 hypertension and one or more of the following: target organ damage, established cardiovascular disease, renal disease, diabetes, or a 10-year cardiovascular risk of greater than 20%. You should offer medicines to anyone with stage 2 hypertension, and if you find high blood pressure in anyone less than 40 years old, they should seek specialist advice. The next 3 slides are going to come in the form of a large flow diagram that sums up the nice guidelines on hypertension. At this point, you're not treating your over 80-year-olds with just plain old stage 1 hypertension, and you've already sent your less than 40-year-olds with hypertension to specialists. If a patient walks through your door and their clinical reading is less than 140/90, but they do complain of the complications of hypertension, you need to check them for target organ damage. By target organ damage, we mean that we check the eyes for retinopathy, the urine for protein, which could indicate kidney problems, and the left ventricle of the heart and aorta for any signs of damage. If you do find some target organ damage, you need to investigate these patients with a bit more scrutiny to check for alternative causes. If there are no signs of target organ damage, then you've got a patient with low blood pressure and they don't need any treatment in the near future. You can review these patients every 5 years. When a patient walks in and their clinical reading is above 140/90, there are a lot more things you need to think about. For example, do they have a pheochromocytoma? You would need to refer these to a specialist the same day if this is something you suspect. Do these people have evidence of target organ damage, and you need to assess their cardiovascular risk? Do they have severe hypertension? If so, you need to start antihypertensive treatment immediately. You will also need to check the retina of these patients for any signs of damage. Offer patients with a blood pressure reading of over 140/90 ambulatory blood pressure monitoring, or if they can't tolerate that, home blood pressure monitoring. After all this, if their blood pressure is less than 135/85, review them 5 yearly. If it's over 135/85, we need to think about pharmacological management. So now we need to think about managing our patient. We can start by offering lifestyle advice such as taking up a good diet and exercise, reducing alcohol consumption, smoking cessation, and reducing sodium and caffeine intake. Clinical commissioning groups might release some healthy eating strategies which could be helpful, and also don't prescribe any calcium, magnesium or potassium supplements. As mentioned before, if an individual under the age of 80 has stage 1 hypertension, they receive treatment just as someone with stage 2 hypertension would with any of the following: target organ damage, established cardiovascular disease, renal disease, diabetes, or a 10-year risk of a cardiovascular event of greater than 20%. Whether the patient takes the route shown as A, containing ACE inhibitors or angiotensin II receptor blockers, or the C and D route containing calcium channel blockers or thiazide diuretics, is dependent on renin dependency. We cover this renin dependency more in later videos, but essentially what is happening is younger people, by this we mean under the age of 55, are more likely to have essential hypertension due to high renin, so we can use drugs that target the renin-angiotensin-aldosterone system. However, people of Afro-Caribbean descent and those who are older than 55 are more likely to have hypertension not due to high renin. For the A route, we normally start them on ACE inhibitors, with the exception that there is the possibility that they are pregnant, because ACE inhibitors and angiotensin receptor blockers are teratogenic. Or, if the hypertension is obviously secondary to increased sympathetic drive, in which case we start them straight on beta blockers. The contraindications and adverse effects of ACE inhibitors will be covered in a later video. Alternative treatments are angiotensin receptor blockers, and if these are not tolerated, then we move to beta blockers. As for the opposite C and D route, we start them on a calcium channel blocker unless they have edema or heart failure, in which case thiazide diuretics are appropriate. As before, if the individual is intolerant to the first choice, switch to the second line choice. More information on first and second line drugs can be found in the BNF. Continuing on from the previous slide, we will highlight some of the contraindications for beta blockers that occasionally come up in exams. Beta blockers and calcium channel blockers in unison can increase the risk of heart failure. Secondly, beta blockers and thiazide diuretics in unison can decrease the threshold for diabetic symptoms and increase the risk of diabetes. If the monotherapy is ineffective, you can now combine one drug from group A with one from C and D, whichever is the most appropriate. If that doesn't work, then combine the calcium channel blocker with the thiazide diuretic, unless it's contraindicated, with any from the group A group. If this doesn't work, add another diuretic, like a loop or potassium sparing diuretic, making sure to take pre-therapeutic blood potassium levels, or you can add a beta blocker if not already on one. And if by this point the hypertension still isn't under control, at this point it's someone else's problem and you can refer to a specialist. Those last few slides were quite busy with information. Luckily, the British Hypertension Society have come up with this image to help determine what treatment someone should be on. Take a moment to familiarise yourself with it, but remember to continuously check NICE and BHS guidelines for the most up-to-date information. These are the drugs that we have mentioned so far. The other diuretics are not used as often as the thiazides in hypertension. Alpha blockers are used in conjunction with beta blockers in pheochromocytomas. All of these will be covered separately in greater detail in later videos. Finally, we need to keep the patient in good health. It's important not to skip steps in the pharmacological management because unnecessary drugs can give unnecessary side effects. Instead, we want to administer just the drugs that are required in order to maintain optimum health. If the individual was hypertensive previously, but is now in remission, or is queried for hypertension, then we check for evidence of target organ damage. As we've mentioned previously, this term means looking for complications that are visible when looking at certain organs. Hypertensive retinopathy for the eyes, left ventricular hypertrophy or signs of heart failure in the heart, and hypertensive nephropathy for the kidneys. If there are no signs of this, then we review them in 5 years. Obviously, if we find complications suggestive of hypertension but with no hypertension actually present, then we look for alternative causes for these signs. Lastly, we review patients with controlled hypertension yearly. Ideally, we will wish to review uncontrolled cases before then, but at the discretion of the doctor due to the variability of action times for drugs. And that just about wraps it up. Keep in mind that this talk was created using NICE guidelines available in 2015, which are actually up for review later in this year, so if you're actually using this in the field or close to exams, double check to see that major details haven't been changed. We hope that you found this helpful. Check back in the not too distant future for in-depth analysis of the pharmacology of all the drugs mentioned in this presentation.